Lovely. Thank you for joining us today for our Health in Action work group. My name is Emily Bear, and I'm one of the site engagement coordinators with MVC, and it is my pleasure to be facilitating this work group for you today. There we go. So our agenda for today's work group, I'm going to go through just a couple of housekeeping slides as we usually do, and then we will have a presentation from some members of Michigan Medicine on advancing post-surgical recovery through early ambulation, a multidisciplinary initiative. And then we will have a chance for discussion and question and answer after their presentation. Just a couple of notes before I introduce our presenters. First, this work group session is being recorded, and I will share that recording along with the slides in our follow-up email. Just give me a little bit of time after the work group to collate all of those materials for you, and I will share them before the end of the day. Second, a reminder to please double check that your mic has been muted and remains muted throughout the presentation. We'll have a chance for a question and answer and discussion after the presentation. But if you come up with a question throughout the presentation and would like to submit that in the chat, we will be monitoring that, collecting those questions for the end of the session, or if it's throughout the presentation, we'll do so. All right. For those attending the work group for P4P credit, we look forward to your active participation throughout the work group. This will mainly come in the form of discussion at the end of the work group today. We don't have any polls throughout the presentation. We will also be sharing the post-work group survey at the end of today's work group. That link will be provided in the chat, as well as in the email sent following the work group that I mentioned. For hospitals that are participating in P4P and would like to receive credit for this work group, that survey is mandatory, as is remaining on the call for at least 80% of today's work group duration. And as a reminder, please, in that survey, note the hospital that you are attending on behalf of, so that we can appropriately distribute your attendance credit. All right, today's presentation is going to be led by 3 members of the Michigan Medicine team: Mary Nowlin, Niki Farquhar, and Heidi O'Neill. Mary has a Bachelor of Science from the University of Michigan and is a graduate of the Physician Assistant Program at the University of Osteopathic Medicine and Healthcare Sciences in Des Moines, Iowa, now known as Des Moines University. Mary has been with Michigan Medicine since 2002. She started in the emergency department for about 8 years and then transitioned to the general surgery inpatient team. From there, she transitioned to the urology specialty group and has remained there for the last 12 years. In 2019, she started working on length of stay reduction projects with the surgical triad. And during this time, she worked on Activate, a length of stay project that originated in colorectal, then expanded to ortho, neurospine, and continues to spread across the surgical services at the University of Michigan. Mary specifically worked with Niki to help develop the nodes for the surgical service teams. Niki completed her master's degree in industrial and systems engineering and a dual undergraduate degree in industrial and systems manufacturing engineering, all from the University of Michigan Dearborn. Her primary career focus has been in process improvement, using data with lean methods to improve systems. She started at Michigan Medicine in 2015. And in her current role, Niki is the project manager lead for the Delays in Care Progression Project Workstream within M2C2, which we will learn a little bit more about today. She is currently leading the creation of patient progression and length of stay reduction tools by identifying, visualizing, and acting on barriers and delays to patient progression and discharge. And she assisted in the design of some of the tools in M2C2. Heidi completed her bachelor's and then a master's degree at the University of Toledo in exercise science with a concentration in cardiopulmonary rehabilitation. She's worked in continuous improvement for 9 years, touching many areas, including adult emergency services, operating room, inpatient, and outpatient settings. In her current role as a project manager lead for the Continuous Improvement Division of the Quality Department at the University of Michigan, her projects are centered on length of stay reduction and readmission avoidance. So welcome, Mary, Niki, and Heidi. I'm now going to pass the baton to our presenters for their presentation.
Well, thank you so much for the great introduction, Emily, and we are very excited to present to MVC today. So thank you so much. Next slide. So we're going to talk to you about Activate in early ambulation today, and also looking at leveraging our command center and care paths to provide real-time notification of delayed postoperative ambulation. So here at Michigan, as many of you are aware, is we have acronyms for absolutely everything. So Activate, here it is, advancing care, treatment efficiency, innovation, value, and teamwork for surgical episodes. So we got together a multidisciplinary team to work on innovation and communication to drive those patient experience and outcomes, and looking how we can support that. Next slide, thank you. So the timeline here for Activate programs and the Command Center real-time alerts. We started back with colorectal Activate in 2019, moving on to Spine Activate in 2021, and then going bigger and better, moving on to 4B, which is a unit at University Hospital. So for 4B Activate, we started in 2022. And then we started incorporating the work from Niki and her team for M2C2 with post-surgical care paths. And there's a lot of little trickles in here, starting back in June of 2023, and then looking at acute care surgery services in November of 23, and then those ambulation alerts starting with neurosurgery February of 24, which is about the time that we started fifth floor Activate. So units 5A, B, and C at University Hospital in 2024. And then also the last thing, it's not the last thing, but the last thing on this slide here is going full live with all services for that ambulation alert in November 2024. So why do we select these programs? So first, what we were focusing on was services or units that have a high observed to expected length of stay greater than 1, and then also looking at that high surgical volume with that leadership engagement. So here at the bottom with our programs, we started with colorectal, that we had a high volume. They had that ODE greater than 1. They also had the ERAS protocol, so enhanced recovery after surgery and high physician engagement. Moving on to spine, same kind of thing here. We want to make sure that every program we had something to progress and be able to make a real impact. After those two programs, we moved on to 4B, so a bigger unit, not just looking at a specific service, and then went to the fifth floor, which we're currently wrapping up right now. So more to come. So now I'm going to hand it over to Mary.
Thank you, Heidi. So working with each of the services, as we talked about, we started with colorectal, and what we did is we sat down with a surgical surgeon leader and part of their APP team, and discussed what procedures had a longer length of stay and where we thought we could move the needle to help them decrease the length of stay. So some of the things that we talked about is making sure the patient is up and ambulating. We did not have a very good track record on ambulating our patients post-operatively, so we knew that was going to be a big heavy hitter of where we really wanted to focus our work, is to work with early ambulation. We also wanted to make sure the patient had some patient education of what they needed to do to progress along their path to being discharged. So we did patient care paths, and we worked with the team, and what do you want to do on post-op day 1? What can we speed up for post-op day 2 to help progress patients along the way? And we also worked on looking at early SAR detection, knowing that the patients come in, a lot of these patients are already debilitated. Now they're having a major operation, and they didn't really think about how they were going to recover at home or what their recovery was going to be like. So we started looking at what we needed to do for early SAR recovery, which I will talk about next. But as we moved across the surgical services that we were working with, again, we started with colorectal, then we moved on to spine, working with that team of what can we do to help your patients get up and progress faster? What can we do to help the delay of discharges? And physical therapy was one of the ones that came up for that team. So we worked with them, if they thought the patient was going to need physical therapy, we put the order in the day of surgery so they would be able to see them the next day. Moving across the different services, we went to 4B next. Again, looking at what we needed to do to decrease length of stay, continuing to work on ambulation. Ambulation continued to be our big go-to to help decrease length of stay. We looked to see what was happening on the units, and we noticed that patients were coming up from the PACU and they were just being hover matted over to the bed. And then it would be another later that night or the next day sometime that the patient would get up and ambulated. So we worked with a transportation team, set it up so they would bring the patient up from the post-op area, have them in the hallway, go get nursing staff to help do a quick assessment and walk them to their bed. And there we go. There's our first ambulation. And then as we moved on throughout each of the services, we also noticed that their order for ambulation, if some of them didn't even have order for early ambulation, and if they did, it was up as tolerated with assistance as needed, and get up and do anything. So we worked on changing the order sets for each project as along the way. And after we continued the 5th floor, now every surgical service has order sets that were appropriate for the service for early ambulation to have the patient up and ambulating within 4 hours of hitting the unit. And then also have ongoing ambulation where it has 2 different order sets. The early ambulation will fall off within 24 hours, but then it has a sustaining ambulation order set to have the patient getting up and walking at least 6 times a day and getting up to the chair for meals at least 3 times a day. So each time we worked with all the different services a little bit more, we kind of learned a little bit more along the way of what else can we do to help progress and get our patients up and ambulating. Okay, next slide. So this is the video that I started talking about a little bit. Another thing that we noticed that was causing delay is for those patients that needed to go to a SAR. A lot of them weren't thinking what was going to happen after my surgery. So we created this video with our hospital at home team, and it discusses with patient readiness for their home, little things like moving rugs out of your way, but it also talks about early ambulation because we didn't want post-operatively to be the first time patients were hearing that we need to get you up and walking. We had the surgeons are starting to incorporate that in their discussion in the clinic, but also this video talks about it as well. And it also brings up to them, like if they feel that they might need to go to a facility post-operatively, to start looking at that ahead of time, go visit them. And it gives them, there's a website that they can go on to, a government website, not biased by U of M, that they can go into and look for ratings. So this video gets put into their portal a couple weeks before surgery. Next slide. In the video, we actually have over 8,500 hits on it. So people are seeing that video. It's very exciting. So here's just a little bit of our screenshot of our data. Colorectal, again, being the first project we worked with, their baseline for ambulation post-operatively within 4 hours was 11%. So over the course of time, they're doing a lot better. You can see the most recent one that we had for March was 77%. So up and down, keep introducing more interventions to help with that ambulation. can see a big dip going down. A lot of times there's other projects that the units are starting to work on. There's staff turnover. There's a lot of different reasons of why there's up and down, but it was good to see a progression. Once we got the first set of ambulation orders, just recently went live into the majority of the surgical services. Colorectal already had it since early 2019, or when we started working with them in 2019, but it was only in 4 different procedures. The first project we did only worked with 4 of their procedures, so then it got added on to the rest of the procedures that they do. So it was nice to kind of see a little spike go up there, and it'll be interesting to see where that data takes us. The next service was spine. One of the M plan directors was on the 5th floor, worked with ortho and saw what we were doing with colorectal and really wanted us to work with his service. So spine, again, we picked up 4 procedures, and those procedures for ortho were the same procedures that neurosurgery did, but they treated patients differently. So this was a good opportunity for us to merge those 2 procedures. So whether you were having those procedures done by orthopedics or neurosurgery, you were having the same treatment plans as best as we possibly can, certainly dependent on patients' recovery time and what was going on with them, but try to streamline their treatment plans. So their baseline ambulation was 23%, and now they're up to about 70s. Slide. So this was with our 4B unit. We realized, okay, we're doing okay with the service base. Now let's go a little bit bigger, a little bit broader, and do a unit base. So there was 11, 12, or 13 different services that admit to 4B. So we looked to see what were the top 4. So what services had most of their patients placed on 4B, and it was otolaryngology, oral surgery, plastic surgery, and the rest of neurosurgery. So working with those 4 units, we had a physician champion, an APP team working with that. And again, early ambulation was our key thing that we worked with. And they've had a little bit more of a struggle. Their patients are complex and they have more turnover. So you can see that there's a big up and down, and they're one of the first units to move over to the pavilion. So their focus right now is the pavilion. So we'll continue to work with a little bit more of the ambulation with them. But the next slide. This is our one that we are working now across the 5th floor. So each time we're getting bigger, broader. The 5th floor already had part of colorectal, was on that part of ortho. And so some of them have already been part of the Activate teams. So it was a good place to work with because the nurses were already familiar with getting our patients up and ambulating. So we have a little higher baseline, like 45%, but now we wanted to bring it across the entire floor and add it to all the different surgical services. So here's our data of where we're at with that. This, again, with process improvement, trying to see what can we do to increase our ambulation numbers. We started doing little competitions, little friendly competition across the units where they would have this little golden shoe, and depending on who had the highest numbers for week, that shoe would transfer from unit to unit. So you can see there was a nice little uptake in when we were doing that. And then early ambulation orders, again, the first phase went April 16th, and then there was a couple other services that were added most recently on May 21st. But we can see the trend line there in the background, a nice little dotted gray line has a slight increase. So we continue to work on it, tweak it, but it's nice to see a little bit of an incline. So we'll see where these new order sets, the data is probably lagging a little bit. So it'll be interesting to see where it goes. So along this process, the command center was starting to ramp up, and Niki started working with the command center. And so we would meet and make sure that we were combining the Activate projects of what we were working on with nodes that they were going to follow. So I helped her progress and make the nodes for surgical services, because certainly we didn't want to have one project working on one thing and another project working on something else and them not syncing. So we made sure we were kind of working on the same thing, making sure the nodes were following what other projects were doing. So I will hand it to Niki and let her go from here.
Thank you, Mary. So as Mary said, we added in this additional feature of the care paths through the command center, which is what you might have heard referred to as M2C2, which is Michigan Medicine Capacity Operations Real-Time Engagement Center, and which opened in November of 2022. And within M2C2, there are multiple functions. Our department that works on inpatient flow, bed placement, is within M2C2. Our transfer center is within M2C2. But really where this work comes into play is that middle box on the left, reducing length of stay. So we've had many different approaches to how can we identify patients that are experiencing some kind of delay, whether it is within their length of stay or on day of discharge. And in order to do that, one of the avenues we took was creating care paths for patient populations. If you can go to the next slide. Thank you. And for those care paths, we created this framework that we were going to use within M2C2. And that is working with key stakeholders from certain patient populations. So each care path is specific to a patient population. We had 9 go live with our M2C2, and post-surgical on the adult side was one of those areas. So we met with those key stakeholders, Mary being one of them for post-surgical, and developed this care path that is a set of milestones that are genuinely expected for that population to move through during their length of stay. And in order to create those milestones, each milestone has a threshold for it. So as a patient moves through these pathways, if they were to only move through what you see as the blue boxes in this process flow, they would move along an on-track state the whole time. But for each on-track moment, we also create this criteria to say, what would mean that a patient is off track here? And to do that, we use our data that we know for length of stay, expected length of stay. We looked at readmission rates in some places in order to understand where is that threshold for when we would say someone is off track. And then what we do is we create that pairing and information of that real-time awareness that this patient is off track with a standard operating procedure, some real-time intervention to get the patient back on track as a way to reduce length of stay and kind of virtually create increased bed capacity without actually having to put a new physical bed in place. So if we move to the next slide, I can walk through. This is what our post-surgical care path looks like. I'll focus just today on the part highlighted in yellow, but as a high level, we have pretty much every adult patient. There are some exclusions, example, cardiac, oral surgery. Some specific procedures don't join this path, but almost every adult patient will join this care path monitoring when they leave the OR. And we look for some key milestones here. You leave the PACU, you ambulate, you have your Foley removed. If applicable, physical therapy evaluates you, you have a diet advancement, pain management is under control, and then you meet some key preparing for discharge milestones. And then you'll see at each of these steps, we have ways for a patient to move off track. And each of these steps also has some built behind exclusions. So I've called out here for ambulation, we allow patients to skip this monitoring if they are contraindicated in some way. So if you have an active bed rest order, seizure precautions, for example, if paraplegia or quadriplegia is on your problem list, we're not going to flag you as being off track because you haven't ambulated yet. So there's a lot more additional logic that lives behind this inner system than what you're just seeing on this page. But as a high level, what we did here is we took this post-surgical population and worked to kind of match what Activate had been doing and what they had been kind of using as their slogans and kind of awareness that the units would be familiar with. So for the care path monitoring, when a patient reaches the unit, we move you off track at the 4-hour mark, really, after you move to the unit. But what we do in our M2C2 area is we start flagging those patients at the 3-hour mark, knowing that the goal that Activate was reaching towards is we want patients to have that first ambulation event within 4 hours of reaching the floor. So we start to highlight patients at the 3-hour mark to give ourselves a chance to still meet that 4-hour target. You can move to the next slide, please. So what we do once we start highlighting those patients in M2C2 is we have our set of standard operating procedures, which are developed with those key stakeholders. So in addition to anybody who helped develop the care path milestones, when we get down to a level of a specific step like ambulation, we might pull more people in for the development of that standard operating procedure, which is our tool that tells M2C2 exactly what they should do when we put one of these patients on their alert list to highlight them. So when a post-surgical patient is identified to have not ambulated yet at that 3-hour mark, what do we want our role in M2C2 are called our clinical expediters? What do we want them to do? It tells them specifically what to look for in a chart review, who should they contact if they do this chart review and they didn't see any other evidence of ambulation? Who should they contact? How should they contact them? And anybody really who's involved in the documentation or ordering of that action is involved in creating that process for us. This here is showing a number of 260 alerts per week. That is inclusive of our entire post-surgical care path, which right now has this alert for ambulation, but we also are alerting our patients that are off track at the Foley removal phase of the post-surgical care path as well. So that 260 is both of those combined for that post-surgical population. Now we have 238 average discharges per week for this population. So as you can see, some patients will flag for both ambulation and Foley delays, and some might be one or the other, but we do have a lot of work still to do here in this early ambulation. And this is very early on. If you remember back to that timeline slide that Heidi presented, we went live with this ambulation alert for all patients that joined the care path in November of last year. So this is still really early on in this approach to improvement here. One thing that is really helpful utilizing our M2C2 clinical expediters to help with this real-time intervention is that every time they work one of these alerts, they're tracking what they find. What did they find in that chart review? If they did reach out to nursing or provider, what was the response back that we learned was the barrier to that patient's ambulation? And then we're able to use that in partnership with our trending data to help do further improvement, with that goal being that over time we're able to reduce how many patients are alerting for this real time. I haven't ambulated yet, but I'm at least 3 to 4 hours on the floor post-surgery. You can move to the next slide, please. So this is an example of one of our communication flyers for before we put this alert in place within M2C2 that we sent out to nursing and providers, and oftentimes we'll also just post in our service rooms on the floor, just helping people understand why are we putting this in place. So on the left side, we tend to focus on what is the benefits of why are we doing this work? How are we identifying the patients that we would flag for this? And then where were we at data-wise before we went live? So when we went live with this, we were at about 67% of patients were showing no ambulation at that 4-hour mark. And those patients had a 40% higher average length of stay when we excluded our top 5% outliers there. So we tried to give everybody a good understanding of the why, both in a sense of why would this be good for the patient, but also the why in terms of our data. And then on the right-hand side, a very high-level overview of what happens when a patient flags for this alert. So I've already talked through that a little bit, but Clinical Expediter does a chart review. They will look for things like free text comments and a note that indicate a patient ambulated. And maybe it just wasn't documented in the discrete place where we check that for our data. And then they'll reach out to the first contact nurse and provider for that patient. And then we set up some kind of roles and norms here. So what do we expect to happen if you do get contacted about your patient? We want help understanding what is that patient's barrier to ambulation. If there are any barriers that M2C2 can help with, the clinical expediter has pathways that they can help. So if the barrier is something to do with needing some kind of DME for that patient, clinical expediter might be able to help understand, is it ordered? Where, when is that going to make it to the patient? If you need a wheelchair to follow safely behind your patient, but you can't find one on your floor, clinical expediter can help work with patient equipment to get one up to you on your floor. Just as some simple examples there. And then, as I said, they will track all of that for us so we can see our trending data on the back end. You can go to the next slide. Thank you. As we have rolled this out, so we're a little over 6 months in, maybe 6 full months of data at this point. We did have a few lessons learned along the way, some specific to this ambulation piece, some specific to our care path work, but some build challenges. Building the care paths in this way does require a lot of complex rules and logic in the system. We've had to do a lot of testing along the way, during build, during our go live, to validate that the path was moving patients appropriately all the time. And then a fun activity of every time our EMR system gets an update, we go back through and revalidate, because sometimes updates can break those rules. And we want to make sure that we're not false alerting on patients. So there's definitely build challenges and upkeep with this system. But it definitely, I think we're seeing the impact that makes that worth it for us. And then there is an element of timeliness for documentation when we are doing things that are so small of a window of time. We are alerting on patients at the 3-hour mark after reaching the floor, and saying this patient hasn't ambulated yet. So timely documentation can often create false alerting for us. If the nursing ambulated the patient, they haven't had time to document it yet, or they documented it in free text somewhere that we can pick up on that manual review by our clinical expediters in M2C2, but it's then hidden in our data on the back end, because we can only really cleanly check that when it's documented in our discrete ways. Another kind of lesson learned is just this continuous need to communicate, and continue working on this culture. When we put M2C2 in place and opened it, this clinical expediter role was brand new. This concept of a centralized department that is helping monitor patients, helping identify patients that might be having a barrier, and that communication between them and nursing, providers, ancillary departments, that's a whole new culture. So really continuing to communicate what we're doing, why we're doing it, and what data we've seen so far has been a lesson we've kind of had to continue ramping up along the way. And then just that continuous improvement, using the data we get to continue working towards how do we reduce the number of patients that are alerting. You can go to the next slide. I have a little bit of our early data here. Thank you. So this was pulled in March. So this is a look at the first quarter of 2025, which again is still very early on. But for our ambulation alert, we had logged 1,280 patients alerting, where just about under half of those we did reach out to someone on the care team. So 559 times in that first quarter, somebody was contacted to help understand what's the barrier for this patient's ambulation. Is there anything we can do to help? How do we get that patient on track here? I split the data out a little bit, different ways that we'll see in the next few slides. But on this one, we looked at patients that went to a non-ICU post-op unit versus patients that started their post-op journey in the ICU. A little bit different pathway that they will have for ambulation. We do not alert on patients for delayed ambulation while they are actively in an ICU or moderate care level of care status. But we did separate out for here depending on where they went post-op. So early on data here, about a 7% decrease in the average time to first ambulation for those non-ICU patients, and a 23% decrease in the median time to first ambulation for patients that went to an ICU to start with. So very similar across the board, 7.1 decrease in the average time, but did want to call it that we are seeing a larger decrease in the median time for patients that go to the ICU as their first post-op. So we are seeing a little bit larger decrease in that tail and that distribution there. And when we compared this population to our population that would have been in this care path had it existed and in a time before we put any actions in place, we're seeing a 0.34 day decrease in average length of stay. So we're continuing to monitor this. It does look pretty promising in these early stages, but we are still very early on. If we go to the next slide, I have a little bit of a different view that is looking at our time to first ambulation in terms of hours here. And this is looking at everybody together. So no separation of ICU versus non-ICU where you started post-op, but looking at our baseline period of time. Then we had a 3-month period of time where we were only testing this with our acute surgery services, and then we added in neurosurgery before we did a full live with everybody. So you can see our baseline average was about 14.7 hours for our average time to first ambulation. And then with our full go live kind of early data, we're down to about 13.58 hours for average. So a small but meaningful decrease here and continuing to understand what are those barriers. And I'll talk a little bit about some of the things we've identified on one of the upcoming slides. But I do have one more different view here that we've looked at. If you can go to the next slide, kind of similarly, trending time, but looking here instead at what proportion of our patients are meeting that 4-hour target. So our baseline here with this full population, now where this differs from the data that Mary had, Mary's data was looking at, in some cases, specific procedure sets of data, specific services or floors. This is anybody who joins our post-surgical care path. So it's also not only limited to our surgery services. If one of our non-surgical services has a patient admitted that has surgery, they will also join this path, which often land on units that wouldn't have been as familiar with that activate work, and they tend to have a little bit of a higher time here. So this 26% of patients in our baseline for our care path data were ambulating within 4 hours. We saw some good improvement with our ACS and neurosurgery during our testing phases and expected a little blip back down when we went live with everybody because we were pulling in all those other services. But so far in these early stages, full go live, 32% of patients meeting that 4-hour target. So again, a small improvement, but we think meaningful. Everything's moving in the right direction. If we move to the next slide, I have a little bit of an insight into what M2C2 is understanding when they work these alerts for us. So kind of our biggest barrier or gap is that this false alerting concept for patients that have ambulated, but it's not documented. And this encompasses both patients that they ambulated and nothing was documented, as well as patients that ambulated, but it was documented in the note instead of in the flow sheet row where we discreetly have this information. We are able to capture and find that through that manual chart review to prevent reaching out and kind of doing an extra communication with a team for a patient that we can find through that chart review has ambulated. That's one, I think, of the benefits of doing that with that human review before we just kind of would, versus automatically putting some kind of pop-up in place. But when we work down to what might be actionable barriers, we have kind of two standouts. We have the bucket of patients still that there's no barriers. We just haven't attempted ambulating the patient yet. But one other key thing that has came out as a barrier is pain management. Um, and we are working with our acute pain service to understand some ways that we can help address this and some interventions that we might be able to put in place. And then if you go, I have one more slide of some things that we are going to continue to do. So one thing that we are still working on is continuing to refine our exclusions for patients that aren't appropriate for early ambulation. In these early months, as we've worked this alert, we've already identified specific procedures that it's not realistic to have this 4-hour target for them. Example would be patients that their first ambulation event needs to happen with physical therapy. We've started to build a list of further exclusions that we can put into place for this logic so that we don't alert on those patients. And then we also can pull them out of our data on the back end too, so that we can get a better picture truly of these are the patients that really it's reasonable to expect that they should have or could have ambulated within 4 hours. We're also wanting to kind of improve our visibility within our Epic system so that we can have that visibility not just within M2C2, but very easily identifiable at the floor as well. So right now, the unit, if they wanted to know how many of my patients have not ambulated within that 4 hours, they have to look at a few different places. You have to know who just came out of surgery. You have to know how long have they been out of surgery and on your floor. And you also have to know have they ambulated yet or not. And that is hidden either in their chart in a mix of different patient list columns. And there's some math involved and some thinking. It's not as automatic. It's just an alert or knowing. So working to find some clean ways to provide that visibility at the unit level as well. And then also working to understand, are there ways that we can work with the documentation burden within nursing? Who does this ambulation documentation? How do we pull it out of notes and other areas where they're documenting or other times where they're documenting something that might indicate ambulation so that we can ensure that we get that documented as well. And then continuing to work with our pain service as well. There is now we have, in addition to a provider to provider consult for pain service, we also have a nurse to nurse consult that we're finding many of our nursing partners just haven't been aware is an option to them for these patients. So having M2C2 help offer that as awareness for them that if pain is a barrier, they can place this nurse to nurse consult for someone to come and help assess. And then as Heidi and Mary had mentioned, continuing to roll out on the Activate side, some updated activity orders and keeping an eye on each of those rollouts. How does that play into the care path data as well as the Activate data? And then that was my last slide. So I think if there's time, Emily, I think we have time for some questions.
We sure do. Yeah, we've got about 15 minutes before the hour is up. I just wanted to first thank Heidi, Mary, and Nikki for a wonderful presentation. I was seeing a couple comments in our chat already about how impressive this presentation was. So thank you so much for putting it together. And it was lovely to hear such an in-depth presentation on this. We did have one question just come through the chat from Liz. Um, Wondering any data comparison of time to ambulation with nurse CNA patient ratios. Is that something you're looking at? Oh, Mary, if you're talking, you are muted. There you
Are
go.
you asking of like first nursing staffing, like nurse ratios compared to ambulation? Is that what you're asking?
Yeah, I'm just curious if you're noticing any improved times with, nurses that may have less going on.
We have not looked at that. That's a great question. We have not looked at that. But I can see that being really helpful for the nursing units. That's something that we might have to talk to them about. We have broken down our data to the time of day. We've broken it down to see when the patients come up. Certainly, there's less patients that come out of OR earlier in the morning than in the afternoon and in the evening. So we have broken it down. We have looked at data for early ambulation based on hour blocks, but we have not looked at nurse staffing. Certainly, I guess we can, I don't want to assume, but a lot of times the nursing staffing is less at night compared to during the day, but we have not specifically pulled in data from nursing staffing of whether they have 3 patients or 2 patients to their early ambulation. That's a good thought.
Great
Thanks.
question, suggestion, Liz. All right. Scott put a question in the chat. First off, very impressive work. Is the 4-hour ambulation a pre-checked order?
It is now. So we started back with colorectal and we added into colorectals back when we started working in like 2019, 2020. We put it into colorectal, and then when we moved on with spine, we added it to the procedures for ortho and neurosurgery. And then 4B, we added it to which order sets the teams that we were working with thought it was appropriate for. And then just recently in April, and then phase 2 in May, we've added it across the board. So we worked with all the different services. And we even touched base with medicine and then our cardiovascular, which services want that early ambulation order for their order sets, and then which ones don't. So now how it works, and it's just recently, as of May 22nd, now is in all of them. The early ambulation within 4 hours goes into the surgical services of all that were approved for it, and that falls off within 24 hours since it's not an active one that needs to stay. But then there's another ambulation order that stays in, and it's orders for the patient to get up and ambulate with a goal of up to 4 times with a goal of 6. And then it also wants them up and sitting in a chair for meals. And then if anybody has specific things on their order sets, such as like ortho, they need to dangle first or whatever, we made sure we kept those comments. So we had over 1,000 order sets to go through, and some order sets had specific comments geared towards whatever procedures the patients were having. And as we were adapting the order sets, we made sure that we didn't exclude any comments that they needed for that specific patient procedure.
Thank you.
Yes, our EMR is Epic.
Yes. Yeah, I think that was mentioned a couple times. We're using Epic at Michigan Medicine. I know some folks use other EMR programs.
Yeah. So we did work a lot with my chart hits to Tiffany to help us put all this in.
Had a question from Irene, just backing up in the chat a little bit. First off, have you collected like patient experience feedback related to this? And if so, what has the patient feedback response in general been to this work?
There has been discussion about putting that out there in a survey, but we have not done that yet. The biggest one that we've been hearing is from the nurses that they want to make sure the patient knows that they're going to be getting up and ambulating when they get to the floor. So they're not the first ones telling them, okay, you just came up from the floor, you just had surgery, now you got to get up. So with that, we've been talking with the surgeons to incorporate it into the discussion of surgery. We worked with the pre-op clinic to add that into the discussion with pre-op clinic of this is what's going to happen with you after surgery. And then we had that video that we had shown, we talked about.
Diane had a question. Do you have any data on ambulation times and length of stay related to multimodal analgesia strategies? I'm not familiar with that. I don't know if...
The main thing that we did with anesthesia from our ambulation is if it was documented that the patient wasn't ambulating because they were in pain or nauseous, or too sedated, We did tag along with anesthesia on some of the projects to like what do we need to do to lighten up their anesthesia? That's the extent of what we have worked with so far with anesthesia.
And then I'll add onto that from the care path side. Working with our acute pain service, I think that we don't yet have any data in that, but I think we'll be working to better understand what the pain management post-surgery story looks like and how that impacts it. Um, at a later point in the care path, we start to monitor is your pain under control, but we know that it is a common barrier to ambulation at the start of the care path. So we are going to be working closely with them on that. But haven't gotten into too many specifics yet, other than what are we counting as what your pain management at the end of your length of stay is. And then maybe early on understanding a little bit of uncontrolled pain. And in some early conversations when we were in our test phase with neurosurgery and acute care surgery, there was a little bit of discussion about just the default post-op orders for pain control. And sometimes having a barrier because nothing was, it's prescribed PRN, it's not prescribed PRN and all of that, but we haven't really looked at the data in terms of what the patient was on post-surgery. So I think that we'll be looking at that more as we closely work with the pain service. And I think that maybe we'll have some interesting things we're able to look at then. But at this point, I think we didn't know enough of how to slice the data with that group yet to get to that point.
All right, with an eye on time, we've got 2 more questions in the chat. If anything else comes up, I will be sharing contact information for Heidi, Mary, and Niki, and they are willing to answer questions offline. But one quick question from Jordan, was there a certain distance ambulation had to be counted as ambulation? So more of a detail question there.
Yep, that's actually a great question because for that first early ambulation, we did not set a target. It can be just getting up from the stretcher and walking to the bed or to the chair or from the bathroom to the chair. We didn't set a certain limit. However, which we didn't really get into with this presentation, but we also partner with a mobility team, and they have what's called the Johns Hopkins highest level of mobility that the nursing staff can document twice a day. And that helps to progress the patient's ambulation on a daily basis. It looks to see where they're at. And by the end of the day, we're hoping that they can progress a little bit further, a little further, and a little further. So this didn't look at specific distance. However, we are partnered with mobility team that does want the patient to progress with distance throughout their stay. There's also one about documentation. That is the biggest thing. Like you saw in Niki's data, that documentation was the biggest thing that we are finding that is probably screwing the data a little bit. We know patients are up and ambulating. We see them ambulating all the time. And you were thinking that the data isn't always reflecting that. So we do think documentation is lacking, and we continue to work on ways to improve it. With that, the mobility team, they actually put alerts to fire. It gets fired. The nurses fire 4 times a day. Did you get the patient up and ambulating? Is the patient ambulating? It just kind of reminds them to get the patient up and ambulating, and documentation is the thing that we continue to work together as a team. So there's definitely room for improvement there. And the other thing is, Niki had mentioned too, like they're finding some of the ambulation documentation in a note. Well, nobody's data is able to pull it and extract it from a note. We are trying to remind them to chart it in a specific place in a flow sheet. And so there's work that we need to do around that too. Continuing the education, the nurses talk about it at their huddles on the 5th floor. Reminding patients to document it in the flow sheet, but there's certainly more work to be done around that area.
And then I'll just add to Mary's response for Susanna is that we're trying to figure out how this is incorporated into their regular workflow. So for instance, an idea that was brought up is that looking at ambulation is one of the vitals. So when they are actually coming to the unit and they do their initial assessment, one of those things is like, have I ambulated my patient yet? So it's just trying to figure out those different ways of workflows just because this is something that is new to them in the sense of how their day goes progressively throughout the rest of the day.
Thank you so much, everyone. We had a really great discussion there. I'm going to pull it to a close just so we can get through a couple of additional MVC notes here. I am going to have Rachel add the link to the post-work group survey in the chat now, just for those of you that need to get going to 1 o'clock meetings. I want to be cognizant of that. For those of you that can stay, just wanted to remind you that we will have many more work groups as lovely as this coming up in 2025. In June specifically, for those that are interested, we will have a cardiac rehab work group, which will be focused on cardiac rehab programs across the state of Michigan by Greg Scharf from My Michigan Midland Hospital. And then we will have a health and action work group at the end of June. For those of you that were able to join us for our collaborative wide meeting in May, this will be a continued discussion about system level quality improvement initiatives, which was started at that meeting with MVC's own director, Dr. Hari Nathan. All right. Additionally, coming off of the May Collaborative Wide meeting, just a reminder to save the date for our fall Collaborative Wide meeting. That will be October 10th in Livonia, Michigan, and we hope to see many of you there. Additionally, MVC is currently accepting requests for virtual, in-person, and system-level 2025 site visits. So if you are interested in learning a little bit more about what a site visit is, or if you know what it is and are interested in scheduling that with us, please reach out. I have included the link for the request form on this slide. And lastly, MVC is seeking presenters for upcoming 2025 events, including work groups. So if you too have a QI project that you would like to present on, just like Niki, Heidi, and Mary today, we would love to hear from you. Thank you so much for attending today's work group and for sticking with us for the entire hour. I hope you all have a good rest of your day. That link for the post-meeting survey is in the chat, and it will also be included in the follow-up email that you should receive before the end of the day. Have a good day.